Hi everyone, this video is on spinal anesthesia. I hope that you have already watched the Neuraxial block part 1 video, which has already covered all the important anatomy pertaining to this topic. So we know about the subarachnoid space where we have to insert our spinal needle in order to deposit the drug in the cerebrospinal fluid. And if you have not already watched that video, then I request you to please go through it before watching this one. It will help you a lot. So when we give spinal anesthesia, a good IV line is very important. So we have a very good running IV line. All the equipments, drugs and monitors are prepared as per the general anesthesia case only. And we have to be prepared with the oxygen probe and oxygen mask, the end-tidal CO2 monitor, and we have to follow all the important universal precautions because we are inserting the needle in the sterile space. In case required, the patient may be given opioid as a pre-medication to decrease the discomfort of needle prick. And yes, the skin is prepared with the antiseptic solution and appropriately draped. So first we come to patient positioning during spinal anesthesia. So when we are giving the spinal anesthesia, our motive is to flex the spine so that the intervertebral spaces open up and it is easy for us to put the spinal needle. So we can place the position in various positions like lateral, sitting or prone. In the lateral position, as you can see in this diagram, the patient is placed in the lateral position. It is more comfortable to the patient if the patient is ill or frail because the whole body is supported on the table and the sedation is also possible. And as you can see, the neck of the patient is flexed towards the chest, and also the knees are flexed so that it touches as much as possible to the chest or the abdomen so that the intervertebral spaces open up. Then this is the sitting position. In the sitting position, it is better to, there is better flexion and midline recognition because in the sitting position, the flexion is better. So the midline recognition is better. It is more important in the obese patients in which we are not able to feel the intervertebral spaces at all in the lateral position. And also in the sitting position, the lumbar CSF is elevated. So the dural sac is distended and it provides larger target for the spinal needle. And in the sitting position, saddle anesthesia is possible, saddle block. In the saddle block, we are blocking only the sacral nerves. So what happens is after giving the spinal drug, we make the patient sit for 5 to 10 minutes in the sitting position only, so that by gravity, the drug comes and block the sacral nerve specifically. But in this position, there is this disadvantage that there is a risk of vasovagal syncope. Some patients undergo vasovagal attack during this position. So some assistant is very much important to support the patient in this position. Then the third is the prone position. It is very rarely used. It is only used for perineal procedures in jackknife position, as you can see. Like the patient is placed in this jackknife position and only for hemorrhoids or the perianal surgeries it is used. So how we select the interspace? We select the interspace by the dermatomes, by the landmarks we know, like the Tuffier's line, as we have discussed already in the previous video. So by those various methods, various landmarks, we get to know which interspace we are selecting, and we insert the needle. Then the likelihood of the failed spinal increases as we go caudally. So as we know that the spinal cord ends at lower border of L1, right? And dural sac ends at S2. So we have to give the drug between these spaces only. But there is increased likelihood of failed spinal if we go caudally. So spinal anesthesia is not performed above L2, L3 interspace because above it, there is chances that we may injure the spinal cord. The spinal needles are very important, which one to select. Okay, So for giving spinal anesthesia, we select size 22 to 27 gauge needles. So yes, with the lesser number gauge, the needle is thicker. So it we feel the loss of resistance very easily. And with the thinner, as we go thinner and thinner needles, it becomes difficult for us to appreciate that loss of resistance. So the shape of the spinal needle is very important. There are two types of needle. See, there is beveled or cutting type of needle. As you can see, the Quincke's needle, it is Quincke's Babcock's needle, QB needle. So this is the cutting open-ended needle. So the bevel is at the end of the needle, and as you can see, so it when it enters the ligaments and the meninges, it cuts the fibers. Okay, and these are the pencil tip needles, pencil point with side port. So the ports in these are not on the edges. It is not at the tip. It is only pencil tip. Then the port is slightly away from the edge. Okay, and it is of two types, Whitaker and Sprotte. So it depends on the shape of this port. Okay, so these are close tapered tip. Now we come to the approach. So how we approach? When we are giving spinal anesthesia, there are three approaches. We can approach the subarachnoid space in the midline by paramedian approach or by Taylor approach. So the midline approach, which is used most frequently, and when you start your anesthesia practice, this is the technique you will start with. So it is technically easy. Okay, so as you can see in this diagram, the needle is inserted at top margin of lower spinous process. See, now these are the spinous process of adjacent vertebra. So what we do is that when we're inserting the needle, see, these are wrong techniques and this is the right technique, because by these needles you will encounter the bony landmarks and the needle will not be able to go into the subarachnoid space. But with this needle, as you can see, so we have to go just above, like these are these two spinous processes. So you have to enter just above the lower spinous process. So whichever, like suppose this is the L3, L4 interspace. Okay, so this is the L3 vertebra and this is L4 vertebra. So you have to go just above the L4 vertebra. Okay, and after passing through skin and the subcutaneous tissue, you have to go slightly cephaloid, slightly in the upward direction. Okay, and not just perpendicular, because if you'll go directly perpendicular, you may encounter bony hindrance. So you have to go slightly cephaloid in the direction of the spine. So in needle advanced slightly cephaloid, interlaminar space is slightly cephaloid to the interspinous space, because first you will enter the skin, subcutaneous tissue, then the supraspinous ligament, interspinous ligament, ligamentum flavum. So the ligamentum flavum is in between the two lamina, which is slightly upward as compared to this spinous space. So you move a little upwards in the cephaloid direction. Okay. So in the midline technique, as I've already told, you pierce, the structures pierced are skin, then the subcutaneous tissue, this the yellow one, then this blue, the supraspinous ligament, then this blue interspinous ligament. After this brown or red ligamentum flavum, which gives a feeling of give way, because the fibers are tough and elastic. Okay, so after this ligamentum flavum, you enter this space, which is a potential epidural space, but we are giving spinal anesthesia, so we have to enter the subarachnoid space. So we pass this and we pierce the dura and the arachnoid matter, and as soon as we pierce this, the free flow of CSF can be seen coming out through the needle, and so this is the subarachnoid space we have entered. In the paramedian technique, the point of insertion is 1 centimeter lateral to midline. So as you can see, this is the midline. So in the paramedian approach, we enter 1 centimeter lateral to this midline, and the needle bypasses the supraspinous and the interspinous ligaments, because these two ligaments are there only in the midline. So we know that the supraspinous and interspinous ligaments are bypassed in paramedian technique. And the ligamentum flavum is the first ligament which we encounter. It is the first resistance that we encounter in the paramedian technique. Okay. And then there is this Taylor's approach. Taylor's approach was described by Dr. John A. Taylor, who was a urologist. Okay. So the paramedian technique, it is a paramedian technique only, Taylor's approach also, but it is given to access the L5-S1 interspace. See, this L5-S1 interspace is the widest interspace. Okay. And for this technique, flexion is also not important. So in those patients who cannot flex their spine due to any disease or any pain or any cause, we use this Taylor's approach. In this, the spinal needle is passed from a point 1 centimeter cauded and 1 centimeter medial to PSIS. See, PSIS is posterior superior iliac spine. Okay, posterior superior iliac spine. This we can identify by the presence of dimples just above the buttocks. Okay, and 1 centimeter caudad, matlab downwards, and 1 centimeter medial to it. This is the point where we have to enter to in this Taylor's approach. And the needle is advanced cephalad, that is upwards and medially at 55-degree angle. Okay, so the orientation is based on the width of the sacrum, and we have to enter from this particular point for this Taylor's approach. The anesthetic injection. Now, as we have entered the dura, we just insert our needle for a few millimeters after the dura, and we'll encounter the subarachnoid space, and we can see the free flow of CSF. Okay, if there is free flow of CSF from hub of needle, it means that we are in the right space. Okay, so we can give our drug here. But suppose if we have entered but the CSF is blood tinged, okay, and after that blood tinged CSF, then it is a clear CSF, then also we can deposit our drug, because now the CSF is clear. But suppose if if the CSF is continuously blood tinged, it means that maybe we have entered the vascular space, okay, into the vessel. So we take the needle out and we reinsert a different space. Now if still the CSF is blood tinged, then the procedure is abandoned. Okay, also the procedure is abandoned if there is presence of paresthesias. Like suppose if we have inserted our needle and the patient says that there is numbness, patient is feeling, and so we withdraw our needle, because that means that we have entered into a nerve, which may lead to nerve damage. So we withdraw our needle, and then we ask the patient again if there is no paresthesia and there is free flow of CSF, then we can give the drug. Okay, so the needle, see, this is the needle, it has entered and there is free flow of CSF. So now we can attach this needle, the hub of the needle, to this. Okay, and we have to first stabilize our spinal needle between the thumb and the index finger, with the dorsum of our hand resting on the back of the patient. Okay, so we want that our spinal needle should not move. Then we attach our needle with the drug, the syringe with the drug, and then we aspirate it a little bit, and we see that the flow of CSF is continuous. If the flow of CSF is not continuous, then we have to readjust our needle. Okay, and if the flow is continuous, then we can aspirate and give the drug within in 3 to 5 seconds. We have to give it slowly. Okay, not very fast. And in the end also, sometimes we do not aspirate. Some anesthesiologists don't like to aspirate the CSF. They say that the baricity of the drug changes. This you'll learn subsequently, but in the initial months, what you do is that you aspirate and see the free flow of CSF, and then enter. Then to deposit the drug. And after that, when the drug has been given, sometimes some people do this also, that in the end also they aspirate and see that there is free flow of CSF, and then re-inject to see that the drug has been given in the right position, right space. After the drug has been given, the whole assembly, the needle and the syringe, are taken out simultaneously as a single assembly. Okay. And then the antiseptic solution may be applied and the patient is positioned. So the level and duration of anesthesia. The distribution of local anesthesia in CSF is influenced by these four factors, which is baricity of the solution. Baricity of the solution means density of the local anesthetic used. We'll be studying about this. Then the contour of spinal canal. Okay. Then the position of the patient in the first few minutes. First 5 to 10 minutes are very important. And the choice of the interspace. So how our local anesthetic will be distributed depends on baricity, contour, position of patient, and the choice of interspace. And the duration, how long this spinal anesthesia is going to work, it will depend on the drug selected and the presence or absence of vasoconstrictor in the local anesthetic. We'll be studying about it. So first we come to baricity and the patient position. So the local anesthetic drugs can be we are using for spinal anesthesia can be classified as hypobaric, isobaric, and hyperbaric, depending on density relative to density of CSF. So baricity is density of the local anesthetic relative to density of the cerebrospinal fluid. It predicts the direction that local anesthetic will move after injection into the CSF. Okay. So in the case of hyperbaric solution, as you can see, in the case of this hyperbaric solution, it is the most commonly selected for spinal anesthesia. Okay, it is achieved by addition of glucose. See, when you'll enter, you'll see that every day you'll be using hyperbaric solutions only because it is most common, and it is made hyperbaric by adding glucose to it, dextrose. Okay, this is the most commonly used bupivacaine, 0.5%. It has greater K-flat spread. See, bupivacaine 0.5% is used. It has 80 milligram dextrose, 8% dextrose. So every ml has 80 milligram of dextrose. And the dose can be T10 for T10 level around, see, 0.5% means 5 milligram per ml. So this injection comes as 4 ml ampule. So this 4 ml ampule has 20 milligram of bupivacaine because it is 5 milligram per ml. So 20 milligram. So for T10 level, which is at the level of umbilicus, if any surgery requires a level of T10, like TURP, so in that you give 8 to 10 milligram of bupivacaine heavy. If any surgery requires a T4 level, T4 is at the level of nipples. So till that, if it is required, then 12 to 15 milligram is required. Okay. So onset of this bupivacaine heavy is 4 to 6 minutes. And the duration is, if we are giving plain bupivacaine, then it is for 60 to 120 minutes. That is 1 to 2 hours. It works. Okay. So besides bupivacaine, earlier we were using lidocaine 5% also and tetracaine 1% also. Okay. But they were associated with toxicities. So that is why they were withdrawn. But we used to use those earlier. And as you can see, this is like the spine of the patient. So this is the thoracic area. This is the lumbar area. This is the sacral area. Okay. So the spinal anesthesia mostly is given in the lumbar area, in the L3, L4 space. So if we are giving the drug at this space, it moves both in the Keflard and the caudate direction. So it is widely spread. Suppose we want to anesthetize area above. Okay. So we'll try to give the anesthesia above the L3, L4 level. And so it preferably moves in the above direction. Now you can see that there is thoracic kyphosis. If the patient is lying in the horizontal supine position, then because of the natural curve of the spine, there is thoracic kyphosis. The lowest point is T6. Okay. So the spinal anesthesia drug anesthetizes till T6. If we want to achieve a higher level, we may adjust the patient position to slightly head down to get it to T4 level. Above T4, it may block the cardioaxillary fibers and lead to bradycardia and asystole. So we don't prefer that. And suppose we want to block the sacral nerves. Okay, so either we can give the drug and make the position sit for 5 to 10 minutes. So there is saddle block. Or what we can do is that we can give the drug slightly below this level so that it preferentially goes to the sacral area. Now, after hyperbaric, hyperbaric is dependent on gravity. So that's why we can adjust the level by changing the patient position also. But this hyperbaric solution is anti-gravity. So it moves in the opposite direction to what? Opposite to the gravity. So it is used for perineal surgeries in prone jackknife position, as I already told, or hip arthroplasty, where can anesthetic can float up to non-dependent operative site. Okay. So earlier what used to be done was that we used to use 0.1% tetracaine for that. 0.1% tetracaine. It used to be made like tetracaine used to come as 10% solution. So it used to be diluted with distilled water. But it was very much hypotonic. So it used to cause that 0.1% tetracaine used to cause osmotic stress to the neural tissues, and there used to be nerve damage. So that's why it was also reconstituted with 1/3 or one half of normal saline. But it is very rarely used. Now there is isobaric solutions. Isobaric is same density as the cerebrospinal fluid. It undergoes limited spread in the subarachnoid space. It stays where they are giving the drug because it is same as CSF. So the motor block is more profound and there is more prolonged duration of action than hyperbaric. Distribution is not influenced by a patient position, now we know, because it is same density. Epidural anesthetic solution prepared in saline can be used. So for this, we can use the same solutions as we use for epidural anesthesia. Okay. So it is used for perineal or lower extremity procedures and also for surgeries involving lower part of trunk like hip arthroplasty, inguinal hernia repair. Okay. So after this, these are the drugs we can use, the variety of the drugs. Now, with the local anesthetic, we can use adjuvants also. You know what adjuvants do? Adjuvants are added to the local anesthetic drug to increase their duration of action. So, there are various adjuvants we can use. So, there are vasoconstrictors we can use which increases the duration of action. So, we use epinephrine or phenylephrine. Now, epinephrine, what they do is, epinephrine is used 0.1 to 0.2 milligram only. So the ampule of this epinephrine is 1 milligram. Okay, 1 ml, 1 milligram. So we take this epinephrine in a 1 ml syringe, and in that 1 ml syringe, we use only 1 or 2 segments of it. One segment is 0.1 milligram. Okay, so 1 or 2 segments. So very little amount is needed. 0.1 to 0.2 ml of 1:1000 solution. For phenylephrine, we use 2 to 5 milligram. So only 0.2 to 0.5 ml of 1% solution. So how does they act? The vasoconstrictors, they increase the duration of action due to decrease in the spinal cord blood flow. They are vasoconstrictors, so they decrease the spinal cord blood flow. Now, since the blood flow is reduced, so the local anesthetic we are depositing there is not flushed out. It remains there for a longer time. So this is how they are working. And in addition, epinephrine also has alpha-2 adrenergic analgesic activity. Okay, so it also has analgesic activity and there is small contribution to the analgesic activity as well. But the disadvantage is that the epinephrine increases the lidocaine toxicity. Yes, it increases lidocaine toxicity. It has significant flu-like effects with chloroprocaine. So earlier we used to use chloroprocaine also. Now it is not used, but it used to cause flu-like effects. With tetracaine, it used to cause transient neurologic symptoms. Okay, so we'll be reading about it. And besides the vasoconstrictors, there are other agents also used like opioids, like clonidine. So opioids are added to enhance surgical anesthesia and provide post-operative analgesia. Effect is mediated at dorsal horn of spinal cord. As we have seen in the previous video, spinal cord has dorsal horn and the ventral horn. So it works at the dorsal horn and mimic the effect of endogenous enkephalins. Okay, so what we use is fentanyl is very commonly used. We also use in our hospital 25 microgram, which is 0.5 ml only. And morphine can also be used, which is used very less, 0.1 to 0.5 milligram. One ampule of morphine is 15 milligram. So even 1/10 of it is not used because 1/10 of it is 1.5 milligram. And we use 0.1 to 0.5 milligram, which is effective for 24 hours. But we have to monitor the patient for respiratory depression. And then clonidine can also be used, which is alpha-2 adrenergic drug. Okay, it augments the sympatholytic and hypotensive effects of local anesthesia. So we see that with clonidine, there is some amount of decrease in the heart rate also. So if the patient already has a decreased heart rate or is elderly, then clonidine is not used. But otherwise, it is a very good drug. It is a very good adjuvant to be used. It prolongs the action and gives very good anesthesia. Now the choice of local anesthesia. Now which drug to use? Now we know about the biologicity of the drugs. We know about the adjuvants of the drug. But which main drug we want to use? So we have to see that how long a surgery is gonna be like. If it is a short duration surgery, then earlier we used to use lidocaine. Okay. Now it is not used, but earlier lidocaine was used. Its duration was 60 to 90 minutes only, 1 to 1.5 hours. And it had excellent sensory anesthesia, but fairly profound motor block. But it used to cause toxicities. There was neurotoxicity with lidocaine. Okay. So earlier we used to give 100 milligram, but then the dose was reduced to 60 to 75 milligram. The concentration earlier used was 5%, which was diluted in equal amount of normal saline or CSF and was made to 2.5%. Besides neurotoxicity, it also caused transient neurologic symptoms, TNS. Okay, it is very important and is associated with lidocaine. So it means there is pain and or dysesthesias in back, buttock and lower extremities. So back, buttock and lower extremities, dysesthesias and pain. It was found to be there in 1/3 of patients who were given lidocaine. So there was more risk of this TNS if patient was put in the lithotomy position, like in the urological procedures, during knee arthroscopy, or during the outpatient status surgeries. Besides the lidocaine, the other short duration anesthesias were given with procaine. Now, this procaine was very short duration, but it used to have increased chances of nausea. Though TNS was slightly better, but there was very much nausea. Now, chloroprocaine was also used during that time, but the preservative-free was better. So there was excellent short duration. It was very good for short duration spinal anesthesia. And the adjuvants could be used, which was fentanyl or clonidine. It was not used with epinephrine, as we have already started that with epinephrine, it used to cause flu-like effects. Now, this was short duration. Now, the long duration spinal anesthesia. The drugs for long duration are bupivacaine, tetracaine, and ropivacaine. Okay. So, bupivacaine heavy is the drug most commonly used, and we are also using it now every day. So, it is 0.5% bupivacaine heavy with 8% dextrose. Okay. And then this tetracaine earlier we used to use, now it has been discontinued. It was used as 1% plain solution and it was diluted with glucose to make it hyperbaric, saline to make it isobaric, and water to make it hypobaric. The duration of this long duration spinal anesthesia, if used plain, was 90 to 120 minutes. So it was 1.5 to 2 hours, whereas with shorter duration, it was 1 to 1.5 hours. So bupivacaine is slightly more intense sensory anesthesia, and it also decreases the tunicate pain. So bupivacaine is very important and we use it every day. Now the desired level of anesthesia depending on level of surgery. So we decide which level we want to achieve depending on the type of surgery we have to get done. Okay. So if we are getting done hemorrhoidectomy, then only sacral nerves, only the perianal area is sufficient enough to be anesthetized. So we can give saddle block. So we have to anesthetize S2 to S5. Suppose for foot surgery, so we have to anesthetize till knee of the patient. So L2, L3. For lower extremity surgery, we have to anesthetize till inguinal ligament. So L1 to L3. For hip surgery, TURP, vaginal delivery, T10 level, that is till umbilicus, it is important. For lower abdominal surgery, appendectomy, T6, T7, xiphoid process. For upper abdominal surgeries and LSCS, that is lower segment cesarean section, there is a lot of peritoneal stretching and all, so we need a higher level, that is till T4, nipple. This is the highest level which we want to achieve by spinal anesthesia. Because beyond this, there is blockage of the T1 to T4 spinal nerves which are cardio-accelerator fibers. It may cause bradycardia. The sympathetic block is too much. So you can see, so you know what happens is by this spinal anesthesia or epidural anesthesia, we give sympathetic nervous system block plus sensory block plus motor block. So the level of sympathetic nervous system block exceeds the level of sensory block, and it sensory level exceeds the level of motor block. So highest you will see the sympathetic nervous system block, then sensory block, then motor block. And there is usually there's a difference of two dermatomes. Okay, two levels. So you have, after you have given the drug, you check that which level we have achieved. Okay, for safety and for ensuring that the adequate level has been achieved. So first we achieve the sympathetic block. This we can check by temperature changes. So when we take a spirit swab, and we can ask the patient if patient can feel in that area. Suppose at T10 level, at the umbilicus level, we ask the patient if the patient can feel warmness or coldness. Now, when there is no blockage, then obviously the spirit will be sensed as cold. But when there is when the nerves are blocked, it will be sensed as what warm. Okay. And sensory level can be assessed by sharpness of the needle. So we can prick the needle at various sites and get to know. For motor block, we have to check for the skeletal muscle strength by dorsiflexing the foot. If the patient cannot dorsiflex the foot, S1, S2 level has been achieved. Cannot raise the knees, L2, L3 level has been achieved. We ask the patient to tense the abductus muscles, so T6, T12 level has been achieved. So first 5 to 10 minutes are very important for adjusting the level of block. Now the continuous spinal anesthesia, the continuous spinal anesthesia is that we can leave a catheter inside the spinal space also, inside the cerebrospinal space. So earlier it was a very important method, but now it has been discontinued, or it is practiced very less frequently because of certain concerns. So it permits repeated drug administration as necessary to maintain level and duration of motor and sensory block. There are lower level of advantages that lower dose of anesthetic is required because there is a catheter inside, so we can give the drug continuously. We can give boluses continuously. So that's why very little amount of drug is required. And but yeah, like when the CSF starts to come, then we can insert a very small this catheter through that needle, and this catheter can be placed inside it, but we have to insert only 2 to 4 centimeter, not more than that, because if we insert more than that, then we can damage the spinal cord, the spinal nerves. Okay, so earlier microcatheters were used, which used to be 27 gauge and even smaller, but they were withdrawn because the microcatheters caused cauda equina syndrome. Okay, and also these catheters now, they used to distribute the drug very irregularly. There used to be very maldistribution of the drug because it used to be very narrow catheter, and so the flow rate through these catheters used to be very slow. So there used to be maldistribution, and also through these catheters, we had to give the drugs multiple times. So there was more chances of nerve damage. Okay. Then we come to failed spinal anesthesia and repeated subarachnoid injection. Sometimes what happens is that we have given the drug, but we see that the spinal anesthesia is not proper. There is inability to identify subarachnoid space. So we give the drug in the wrong space, or there is failure to inject all or part of the local anesthetic solution. Sometimes what happens is that the bevel is partly outside the subarachnoid space and partly inside. So what happens is that we give the drugs, little amount of drug goes inside the CSF, and almost all comes out. So there is failed spinal anesthesia. By local anesthetic maldistribution also, if more corded interspace is chosen, then also that it is more prone for failed. So we repeat the subarachnoid injection in these patients, but we have to take care that the combination of 2 doses, that is the first dose and the second dose, should not exceed that considered reasonable for a single injection. We have to take care that we do not exceed the toxicity limit. We have to add the 2 doses, and that is all the amount of drug we can give to the patient. Now we come to physiology of these blocks. So, spinal anesthesia interrupts sensory, motor, and sympathetic nervous system innervation, as we have already seen. Now, the conduction block of small diameter unmyelinated fibers occurs earlier. So, the sympathetic nerves are blocked first because it is small diameter and it is unmyelinated. Okay. And later on, after this, the larger myelinated sensory and motor fibers, which are myelinated. Okay. They are thicker. So that's why they are blocked after, later on. But first, sympathetic nerves are blocked. Okay. And as you can see, the sympathetic block exceeds somatic sensory block by 2 dermatomes, maybe 6 also. Okay, sometimes what we see is that there is hypotension. The sympathetic system has been blocked, but there is the sensory level is very low. So we have to take care that there are disparity in where these levels are achieved. So if suppose there is higher level of motor anesthesia, okay, suppose we have given the drug and the motor anesthesia is very high, so there will be paralysis of the abdominal and intercostal muscles. So patient won't be able to cough properly and expel the secretions. Patient may experience dyspnea also. Okay, many patients, after we give spinal anesthesia, says I am not able to breathe. So it is despite the adequate ventilation occurring, because there is inadequate sensation of breathing. Patient can't feel that he is able to breathe properly, but the ventilation is adequate. And patient is not feeling because of loss of proprioception in abdominal and thoracic muscles. Okay, because they are paralyzed. So that's why. So in that case, what we do is we counsel the patient, we give supplemental oxygen. That is why we have kept the oxygen in the starting. We give supplemental oxygen, we counsel the patient, and we are always ready to ventilate the patient if required. Then if suppose spinal anesthesia is above T5, okay, so the sympathetic nervous system innervation to the GIT is hampered. There is unopposed parasympathetic activity. So what does parasympathetic activity does to the GIT? The intestines are contracted, the sphincters are relaxed, the ureters are contracted, utrovesical orifices relaxed. Okay. So if there is suppose block of the afferent impulses from the surgical side, that is there is sensory block. So there is absent adrenocortical response to painful stimulus. That is why patient don't feel pain. Now, see, also what happens is that there is decreased bleeding during regional anesthesia. You will see that it is less as compared to general anesthesia, because in regional anesthesia, there is decrease in the systemic blood pressure and there is decrease in the peripheral vascular resistance. So during hip surgeries and TURP, you'll see that there is decreased bleeding. If there is sympathetic nervous system block, then you will see that the blood flow to lower limbs increases. Okay. And so regional anesthesia also decrease the chances of DVT in hip surgery patients. So it is advantageous. Now we come to the last topic, which is side effects and complications. So spinal anesthesia is risky also. It may cause neurologic complications, hypotension, bradycardia and asystole, post-dual puncture headache, high spinal anesthesia, nausea, urinary retention, backache and hypoventilation. Okay, so neurological complications. Neurological complications can occur by trauma from a needle or the catheter, or by a compression from the hematoma or the abscess. So we have to be careful. It has to be totally aseptic technique and a skilled technique. So it is more profound if we inject the local anesthetic in the presence of paresthesia. That's why never give your drug, never give your spinal anesthesia when the patient says that there is some numbness he's feeling. And transient neurological symptoms, this we have already read. Pain and dysesthesias in back, buttock and lower limbs. Okay. Then patient may undergo hypotension, which is systolic BP less than 90 millimeters of mercury. So it is due to sympathetic nervous system block. It decreases the venous return to heart and the cardiac output, and there is decrease in the systemic venous vascular resistance. The degree of hypotension parallels sensory level block and intravascular fluid volume. So the treatment is, we have to give moderate head up. Okay. If this is happening, then we have to give a moderate head down, sorry. Then there is adequate hydration. We have to give sympathomimetics. Ephedrine, phenylephrine and epinephrine can be given. Then bradycardia and asystole can occur. due to block of the cardioaccelerator fibers originating from T1 to T4 and decreased venous return, which is Bizol-Zarish reflex. So we have to maintain the preload, aggressive stepwise escalation of treatment. We give ephedrine 5 to 50 milligram, then atropine, then epinephrine. Okay. If patient is undergoing bradycardia and asystole, then epinephrine even 1 milligram IV can be given if it is not getting controlled. So next is the post-dural puncture headache. Now, this is a very important side effect which we need to understand. There is it is direct consequence of puncture hole in the dura. Okay, with loss of CSF. Now, what happens is that when we're giving the spinal anesthesia and we enter the dura, so sometimes the dural hole is very large and there is loss of CSF, which increases the rate of production of CSF, and it leads to downward displacement of the brain. The brain tries to herniate into the vertebral canal. So there is stretch on the sensitive supporting structures, which causes this post-dural puncture headache. Also, it is because of pain from the distension of the blood vessels. Now see, when there is a lot of CSF loss from the skull, so to compensate the volume of the skull, there is distension of these blood vessels, which leads to post-dural puncture headache. So pain begins typically 12 to 48 hours after the dural puncture, though this time may be variable, and it intensifies. The patient gives a very typical history that it intensifies with sitting position or standing position, and it is partially or completely relieved by recumbency when the patient lies down. So there can be occipital or frontal or both headache, which may be dull or throbbing. The risk factors are it is associated with nausea, vomiting, anorexia, and malaise also. There is stretch on the cranial nerve 6 sometimes, and it may lead to diplopia, blurred vision, photophobia, and spots. The risk factors are children after puberty. It is less frequent in children of less age or in the elderlies. It is very much prevalent in pregnant women after cesarean sections under spinal anesthesia. And if there is previous history of PDPH, if the diameter of the needle is large, the type of needle is very important. The cutting needles with the beveled edges are more prone to cause tearing of the tissues, the fibers, and causing a bigger hole than the pencil tip needles. So how it is treated? By bed rest, fluids and analgesics, and caffeine. Bed rest is very important. So we ask the patient after spinal anesthesia to have a rest for 1 day, 24 hours. Fluids are given, analgesics, caffeine, 500 milligram IV. And if it is not relieved by these techniques, then blood patch can be given. So patient's own blood is taken aseptically, 15 to 20 ml, and the injection is made near or preferably below the site of initial puncture because it tends to travel up in the capsular direction. So as you can see, the patient's blood is being taken and we are inserting it into this epidural space and a level below or at the same site. The patient is kept supine for at least 1 hour. Next side effect is high spinal anesthesia. It is a complication. Total spinal anesthesia, which is excessive sensory and motor anesthesia associated with loss of consciousness. Okay, so since it is a continuous space, as we have seen in the previous video, the spinal space it communicates with the brain also. So apnea and loss of consciousness, apnea and loss of consciousness are due to ischemic paralysis of the medullary ventilatory centers due to profound hypotension and decrease in the cerebral blood flow. Okay, so it is because of the decrease in the cerebral blood flow that there is unconsciousness and apnea. So it may also be due to local anesthetic effect above the foramen magnum. So how it is treated? We have to maintain the airway and the ventilation. Most important, whenever you see that there is chances of high spinal anesthesia, just take care that you have to prevent hypoxia in that patient, because otherwise the patient will become vegetative, and this condition is totally preventable, repairable. Okay, so maintain the airway and ventilation, intubate the patient then and there, support circulation with sympathomimetics and fluids. Head down position has to be done, head down position, to facilitate venous return and maintain the cerebral blood flow. I know that some people may feel that already there is high spinal, but if it has extended to the effect that there is apnea and loss of consciousness, that means that you have to do head down position to maintain the cerebral blood flow. Okay, then you don't think that no, we don't want more higher spinal anesthesia. Important is to prevent the decrease in the cerebral blood flow. Then the other side effects are nausea. Many patients, after you give spinal anesthesia, will say that they feel like puking. So during that time, instead of giving MSET, give sympathomimetics, give mephentermine, ephedrine, because it is due to systemic hypotension causing cerebral ischemia. Okay, so it is due to increase in the PNS activity, parasympathetic nervous system activity. Urinary distension can also be there. Urinary retention can be there because spinal anesthesia blocks the bladder innervation. So we are giving larger amount of fluids also, which causes bladder distension. Backache can be there. It can be due to multiple attempts or due to uncomfortable position during the surgery. Hyperventilation is very common. It is due to decrease in the vital capacity. If motor block extends upwards towards the thoracic or the cervical dermatomes. So there is subjective feeling of dyspnea, as we have already discussed, due to loss of proprioception from intercostal musculature. So we have to monitor pulse oximetry and capnography. So this was all for this video. This was the second part of neuraxial block, part 2. And after this, there is third part in which we'll be studying about epidural anesthesia. So do watch that also. And please like, share, and subscribe. Thank you.